Family health insurance premiums have risen 342% since 1999. You contrast that with the rate of inflation, which has risen 64% in that same 27-year span. That's a differential of 278%. So I began to ask myself the question, where is that money going?
This is Real State, a podcast from CSG South. Join us as we talk with policymakers and public leaders shaping state-level decisions across the South and explore how ideas move from policy to real impact.
Hello, and welcome to Real State. I'm your host, Lindsey Gray. Across the country, states are taking a closer look at how health insurance policies affect patients, providers, and access to care, particularly as technology, administrative processes, and healthcare delivery continue to evolve. In Tennessee, that conversation has included a comprehensive proposal this legislative session known as the Patient First Act that addresses everything from claims, processing, and provider reimbursement to the role of artificial intelligence and patient data protections. Our guest today, Representative Dan Howell, has served in the Tennessee House since 2013, and for the last several years, he's served on the CSG South Executive Committee, all while actively engaging on a wide range of policies. Representative Howell, thank you for being with us today.
It's a pleasure to be with you, Lindsey. Thanks for asking.
Thanks so much. So before we get into the details of the legislation, I want to start with what led you to take this issue on, since many pieces of legislation are often shaped by real life experiences. Yeah, you've shared with me that this effort was tied to a personal experience with the healthcare system. Can you tell us about that and how it influenced your decision to pursue this legislation?
It is amazing how things that happen to us in real time have a ripple effect that later in life becomes legislation. It's happened to me a couple of times, not to me personally, but things that happened to some of my constituents that turned into legislation. But in this case, it happened to me. About 2 years ago, my wife asked me to plant a crepe myrtle tree in our front yard. And of course, I love my wife and I was glad to do it. So spent about an hour digging and shoveling, and after I put the tools away, about an hour later, I noticed that I had some severe sharp pain in my right knee, and it wouldn't go away. It kept getting worse, and I noticed by the time it was late evening, I couldn't hardly walk. So the very next morning, I called my doctor, explained the situation to him, and he said, "Well, come in right away. I want to take a look at it." So he said, "I think you've torn a meniscus in your right knee." So he did an x-ray. Not one, but two meniscuses were torn in my right knee, one on each side of the knee. And he said, "Well, I think just to confirm, we better do an MRI." So the MRI, the x-ray, and the doctor who has 25 years of experience as a sports doctor, sports medicine, and orthopedic surgeon, they all three said, "Yes, you have two torn meniscus in your right knee and you need surgery." So as the case is today in medicine, you have to get approval from your insurance company to get surgery. So he said it should be just routine. Well, this one wasn't. My insurance company denied it not once, but twice. And so that really affected my quality of life for about 6 weeks until the vice president of Blue Cross and I had some very candid conversations. Finally, was able to get the surgery, but not before Blue Cross suggested that rather than surgery, they suggested that I have 9 weeks of physical therapy. I'm not a doctor, but I knew that wouldn't work because my kneecap, because of the tear, my kneecap was twisted and tilted, and physical therapy would have made it worse. But thankfully, I was able to get the surgery done, and today both the tree and my knee are doing fine.
Good. I'm glad that both have grown back together and everything is going well. When you step back from that experience, what did it reveal to you about how the system is working or not working for patients and providers? Not everybody gets to call the VP and get this involved or knows how to advocate for
True.
themselves.
Yeah. Well, I had never had an experience like that. I've been blessed all my life with good health. And I think the only time I've been in the hospital was several years ago. I had an emergency appendectomy. And for emergencies, you don't have to get permission to have your appendix taken out when it's inflamed. Yeah. So this was a new experience for me, but it really revealed to me why so many of my constituents and so many of the people in Tennessee and things that I hear and read nationwide are complaining about their insurance companies. In fact, some recent polling in Tennessee during the process of running this bill, there was some polling done. And it showed that while 81% of voters trust their doctors to make the decisions for their health care, unfortunately, 67% of voters have an unfavorable opinion of their health insurance companies. 53% of Tennesseans blame insurance companies for the exorbitant healthcare costs and rising premiums. And while I mentioned premiums, let me touch on that for just a minute, Lindsey. Since 1999, and I found out all of this while doing the research over the last 2 years for my bill, family health insurance premiums have risen 342% since 1999. You contrast that with the rate of inflation, which has risen 64% in that same 27-year span. That's a differential of 278%. So I began to ask myself the question, where is that money going? And so when I took a deep dive into the situation of where we are now, that's where the Patients First Act actually came from.
So it looks like you used a series of data, your perspective, and it clearly informed the structure of the Patient First Act. So at a high level, what problem is the Patient First Act trying to solve?
Well, in simple terms, I want to put medical decisions back into the hands of the patients and their doctors. It's not there now. Health insurance only works when the promises made in the policy, which is actually a contract, are honored in the practice. So in reality, health insurance companies have turned their claims division since 1999 into a profit center, and there's data for that as well, research for that as well, which I don't have time to go into here, but it's real. And when they use a process called delay, deny, and defend, and when the insurer denies a claim and only 1% of the policyholders really understand that they can appeal a denial, then it's a huge profit for the insurance companies.
Right. Well, the bill that you put forward is fairly comprehensive. It established a state-level review commission, set standards for insurance practices, and creates new protections. So can you walk us through a few of the key components you believe are most important in this bill?
Absolutely. I learned through the process that some of these health insurance companies are making unbelievable profits. I believe that's one reason we need a commission of insurance review. And it was actually Speaker Sexton, the Speaker of the House in Tennessee, it was actually his idea to include that in the bill. And like most states, Tennessee has a cabinet-level appointment of Commissioner of Commerce and Insurance, which, by the way, didn't like my bill. But that's okay. That's another story. But also, like most states, the main focus of that department is to make sure that all insurance companies have the necessary reserves to pay the claims that are filed. But when it comes to regulation and following up on complaints and investigating fraud, that type of thing, they do very little, if any, enforcement or complaint investigation. I can give you some examples. A hospital near my district is owed $64 million by a major health insurance company. Another hospital in East Tennessee is owed $65 million by that same health insurance company. And the only way to collect those funds is to sue. Unfortunately, the insurance companies have all the money, most of it, and they have a bank of lawyers, and it's very expensive for a hospital or a medical provider to fight back because of the extreme costs. So to me, it's no mystery why so many hospitals and healthcare providers across the state, across the country are struggling to survive, especially in the rural areas. And that's where the focus is today, is providing quality health insurance in rural areas of our state as well as across the country. The health insurance companies, unfortunately, control the care. They control the provider pricing, the pharmaceutical pricing. They have their own PBMs, and they often refuse to pay what is owed to the provider. And so that's why I believe that a review commission is necessary in Tennessee.
Well, thank you for explaining the role of what the review commission would be charged with. One notable provision addresses downcoding, where claims are adjusted to lower cost procedures. Why was that an issue you felt needed to be addressed?
Well, downcoding is a huge issue, Lindsay. It simply means that an insurance company refuses to pay what is on the claim. That's basically what it means. The service provider provided by the doctor or the hospital is downcoded to a lesser pay scale, and the insurance company says basically take it or leave it. That's wrong, and we need to fix it. For example, I have lots of examples. Don't have time for them all, but a hospital in Tennessee was told by a patient's insurance company to keep that patient for 2 extra days because of some complications in the patient's health. And so the hospital did that. But when it was time for the insurance company to settle the claim, they refused to pay for the extra 2 days. They just said, no, we're not going to pay for those extra 2 days. They downcoded them to a lesser pay scale, and the hospital actually had to eat those costs. And this is why we're seeing more and more lawsuits against insurance companies and more investigations against insurance companies. Downcoding is extremely difficult for the hospitals and the providers because it makes it hard for them to survive. They have to pay their staff. They have to pay for the medication, their time. And currently, the health insurance companies hold all the leverage because they set the prices, and we're trying to change that in Tennessee.
You were the first one to educate me on downcoding, so I definitely wanted to ask you that question. And since then, I've kind of seen and researched a little more states that have done some policies recently on downcoding, which I'll reference a little bit later. But it's a fascinating strategy, and so. The bill also addresses how modern tools and systems are being used in healthcare. The legislation includes a provision around the use of artificial intelligence in claims review, requiring human oversight before the final decisions are made. Why was it important to include guardrails around AI in this context?
I was stunned, Lindsay, in my research while preparing for this bill to discover that health insurance companies use an artificial intelligence algorithm to approve or deny, mostly deny, claims when a patient or a doctor files a claim. Now, I'm not against artificial intelligence. In fact, I use it in my office on certain things, but I never use AI unless I review it afterward. AI is not foolproof. Right. But they're using this AI algorithm to deny claims, and the insurance companies don't deny it. One exec recently, a few weeks ago, before Congress testified that we love AI. We can deny a claim in 4 seconds. That's just stunning to me that they would admit that. And some researchers estimate as much as 81% of first-time claims, like my knee, are denied. 81% of first-time claims are denied. AI is nothing more than a tool. So my bill just simply says you can use AI to flag certain things when it comes through. You can maybe flag what you might think is some fraud, or you can approve a claim that you might think be a good claim. But you cannot use AI without putting some medical eyeballs on it. You have to have a medical professional review of the AI when you use it. And they have to have that medical professional to look at it before a final decision is made.
We cannot forget our critical thinking skills as AI
Right.
evolves.
That's exactly right.
So, again, a comprehensive bill. So there are also provisions related to patient data, particularly limiting the transfer of medical information outside of the United States. So how does that fit into the broader conversation about trust and transparency in healthcare?
This was another stunning example of information that came across my desk as I was researching all of this. It's just amazing to me that our health insurance companies, who we really up until recently have trusted with having the best interests at heart for the patients, are sending up to 61% of claims, according to some researchers, to be reviewed by AI outside of the United States. I just find that incomprehensible. I see all kinds of issues with that. HIPAA laws, violations, reviewers unable to properly read and understand English. The bill simply says, let's keep the reviews inside the United States. I'd like to keep them inside Tennessee, but I was told by legal that may not be possible.
It's maybe a step too far.
Maybe so.
So another theme in the bill is the relationship between insurers and providers. The bill includes provisions requiring notice and negotiation before changes are made to provider contracts or reimbursement structures, which I think we touched on just a little bit. What challenges were you hearing from providers that led to this approach?
Oh, the stories I could tell. But the complaints I hear most are denials. People who have been taking a certain type of medicine for years are suddenly sent notice that we're not going to pay for that medication anymore. Denials. They have to appeal. So many people do not know that they can appeal. Insurance companies practicing medicine without a license. You say, oh, that's a reach. No, I've heard this from medical provider after medical provider who tell me my insurance company is telling me what to do in my practice. They even prescribe what medicine I should give to my patients. That is practicing medicine without a license. Another example I read recently about a doctor, a pulmonologist who had a young patient. He prescribed an inhaler. He had some kind of respiratory problem to a 11-year-old boy. And the doctor prescribed a specific inhaler because of his age, his condition, and the type of issue that he had. The insurance company came back and said, no, you can't use that. We won't pay for that. We want you to use this inhaler. Now, why do we need doctors if we can just call the insurance company and say, I've got a cold, what do you prescribe? That to me is prescribing medicine, practicing medicine without a license, and we need to stop that.
And there are also provisions addressing issues like lasering and ownership structures between insurers and providers. And you might have to explain kind of what that is. But from your perspective, why is it important to look at these structural dynamics in the healthcare system?
Sure. We need to do it to avoid monopolies. Monopolies drive up costs. They drive out competition. We recently had a bill here in Tennessee in the legislature concerning CVS pharmaceuticals. It had to do with PBMs. CVS owns that insurance. They own the health clinics. They own the PBMs, which set the drug prices for their competition. That's just unbelievable that we have gotten to the point that we allow that to happen. I'm old enough to remember years ago when we broke up AT&T because it was a monopoly, but we seem to be fine with the healthcare companies being monopolies and owning all of these things. But CVS alone is credited by some of forcing at least 600 independent pharmacies out of business in my state of Tennessee. So it's a great concern, and we need to put a stop to it. While
this bill did not advance out of the committee this session, I believe it died in the Senate. The conversation around these issues continue. So what feedback did you receive during this legislative process this year to maybe revise this or just further education? What are you hearing, and what's that the next steps kind of look like?
Well, it was a bipartisan bill. I had 45 co-sponsors from both parties on both sides of the aisle in the House. And the reason is because we all recognize the system is broken. It favors the insurance companies and the stockholders and not the patients, not the doctors. And I don't believe a fix will come from the federal government. I believe to bring about change, it's going to take a grassroots effort from states like Tennessee, and hopefully others will join in a coalition to rise up and do what's best for our patients, for our constituents, and for the citizens of this country. But in the House side of the General Assembly in Tennessee, my entire bill moved forward. Because it had a lot of support, with the exception of what's called the equity reimbursement. That means equal pay for equal medical service, which is just common sense. Another example, if I could share one with you real quick. I happened to be able to glance at the reimbursement schedule for one of the larger insurance companies. That schedule allowed a payment of $1,000 for an emergency visit to one of the hospitals close by my district. That same payment schedule allowed $3,000, 3 times as much, for another hospital, a large hospital owned by a huge nationwide company, 40 miles away in a larger city. So $1,000 versus $3,000 for the same service. That's why our rural hospitals and medical providers in the state of Tennessee and nationwide are suffering. Because they're not getting equal pay for equal service. And we need to change that. As you said, unfortunately, the bill was defeated, but just one vote.
Yes.
Defeated by one vote. About the time that it came out of Finance Subcommittee on the House side, that same day, it was defeated by one vote in the Senate Commerce Committee. But I'm not discouraged. We have momentum. The bill is being rewritten and it will be refiled come January of next session. And I'm looking forward to running it again and moving this issue forward.
And it's okay if you don't want to share this, but looking ahead, what aspects of the bill do you think have the strongest potential to move forward? Are you going to make any tweaks or revisions based on feedback you got from this year?
Yes, I think the Commission on Health Insurance Review, very popular in the legislature, not from some in the executive branch. It's very popular. That will also coincide with the AI algorithm, making sure we have medical professionals looking at the actual records, and the part about 60 days notice. Another example of that, I had a hospital near me, which impacted about 8,000 of my constituents. They were notified overnight that they were no longer in the network with United Healthcare for Medicaid Advantage. Well, that was a tremendous issue for about 8,000 of my constituents. Thankfully, we got that worked out. But my bill says that you have to give at least 60 days notice before you put such a burden on the policyholders in Tennessee.
These health insurance questions and issues are not unique to Tennessee. Across the country, states are examining similar issues. We're seeing a number of states take action on various pieces of this legislation. We've been hearing about PBM reform for a couple years. Whether it's downcoding in Indiana and New York, or transparency bills, particularly around downcoding in Arkansas and Virginia, or AI oversight in states like Texas and Maryland. But Tennessee's proposal brings those issues together in one comprehensive framework. I think that's what makes this a little bit different, and why I wanted to talk to you about it on this platform. So for other states considering similar reforms, what lessons from Tennessee's experience would you highlight?
Good question. I would say be prepared for an onslaught of opposition from the health insurance industry. I'm told, I didn't bother to look into it, but I was told that there were 10 high-powered lobbying firms hired to defeat my bill. But you can't be discouraged. Opposition is a fact of life. If you're doing anything right, you're going to have opposition. If you're doing anything good, you're going to have opposition. And that issue, the reason you shouldn't be discouraged is the issue resonates with the people, not just of Tennessee, but across the nation. People are concerned about good quality health care that they can depend upon, and something that affects the patient and helps the patient and the doctor relationship rather than the shareholders of these for-profit insurance companies. This is an issue that resonates with constituents, and it's the right thing to do. And I believe you'll be surprised if someone decides to run a similar bill. They'll be surprised by the support they receive from their constituents, as well as the medical provider community. We had hospitals, the TMA, the Medical Association, Hospital Association, doctors who came to our press conference and asked to speak on the bill. Wow. We had a crowd. And the issue is important. It has a lot of grassroots support, and I believe that we'll take another run at it. We might have a different outcome.
Well, I know this is a layered topic, particularly with a bill that comprehensive, and having both sides of this issue, voices come forward, I'm sure is a very tricky place to be. I am not envious of your role as a legislator in this one, but I have no doubt you'll take another run at it and see what can move forward in Tennessee. So before we close, I'd like to end with a question we ask all of our guests. So what is the best piece of professional advice you have ever received, and how does it shape the way you approach your work today?
I have been blessed along the way with some wonderful mentors in my life, more than one, several. And each one has contributed in some way to any success that I may have enjoyed. But especially as a freshman legislator some years ago, it was impressed upon me that being a legislator is all about relationships. And in reality, that's true in life. I'm just one vote out of 99 in the House. And to get anything done, I get amused when it comes election season and I see people campaigning. And when I get to the Capitol, when I get to the legislature, and I have to smile, because you're not gonna do anything without some help from the team of legislators that you work with. You have to build relationships. You have to build trust. You have to have credibility. You have to keep your word. And if you don't do that, credibility and trust is something that's extremely hard to regain once you've lost it. So I've tried to follow that advice, and so far it seems to have served me pretty well in the House of Representatives, and I hope to continue to do that.
It's been fun to watch you with those relationships, and particularly on our executive committee. So thank you for putting that forward as your piece of advice to our audience. So Representative Howell, thank you for joining us and for sharing your perspective on an issue that impacts patients, providers, and healthcare systems across Tennessee and the South and the country, really. So we appreciate your time and appreciate you educating anybody that decides to listen.
Good to be with you, Lindsay. Thank you so much.
Thank you. And to our listeners, thank you for tuning in to Real Estate. For more conversations like this, visit csgsouth.org. I'm Lindsey Gray. Let's keep it real.
Thank you for joining us today on Real Estate, where we keep it real about what really matters.